Well, I'd like to personally welcome you to tonight's webinar entitled Women's Issues and Mental Health. And it's presented by our usual behavioral health contributor, Dr. Monique Harris Hunter. Dr. Hunter is a licensed clinical psychologist who practices here in the Atlanta area. She obtained her doctorate in clinical psychology from the University of Georgia and has since worked at various sites providing mental health care to adults in both inpatient and outpatient settings. Dr. Hunter is an assistant professor with the Morehouse School of Medicine Department of Psychiatry and Behavioral Sciences, where she provides clinical supervision to psychiatry residents. Her areas of particular clinical interest include post-deployment adjustment issues, post-traumatic stress disorder, use of prolonged exposure therapy for treatment of PTSD, childhood trauma, substance abuse, and interdisciplinary treatment planning. She currently works as an outpatient clinic which provides both primary care and mental health services to an adult clientele. Application for CME credit has been filed with the American Academy of Family Physicians and has been approved for 1 hour of CME. CEU credits have been applied for but are still pending. Please note that questions and/or comments can be submitted to the presenter throughout the presentation. She will field them as possible or when possible throughout the presentation. In addition, there will also be times that she will pause and ask for questions. So please submit them by typing them into the Q&A box at the bottom left-hand corner of your screen and clicking submit. And with that said, ladies and gentlemen, let's welcome Dr. Hunter.
Hello, thank you everyone for attending, and thank you for the introduction as well. In compliance with the American Academy of Family Physicians guidelines, I hereby declare that I do not have financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. So, as was stated in the introduction, I am a psychologist who's worked in a number of settings. I've worked in both inpatient and outpatient settings, residential substance abuse treatment programs. I've worked in day hospital programs or partial hospitalization programs. I currently work in a medical clinic, a primary care medical clinic that provides also mental health services as a specialty. And I'm drawing upon those experiences for tonight's presentation, and we'll also be reviewing some of the literature about common issues in women's mental health, as well as some suggestions for how to address some of those issues. Just to give you a quick word about how tonight's talk will be organized, I'm going to spend approximately the first half of the talk focusing on some social issues that are important for us to consider as clinicians working with women and girls. And then I'll spend the second half of the talk focusing on specific diagnostic categories that are of special focus for women and girls, paying closer attention to those diagnoses that have differential prevalence rates or different patterns of presentation for women and girls. And I will try to also provide some resources for screening each of these diagnostic categories as we get to them in the second half of the presentation. Our learning objectives tonight are to identify important gender-based differences in the etiology, diagnosis, treatment, and prognosis of several key mental health problem areas. We will also explore the biological, social, and psychological bases for some of these differences. My plan is to provide a review of the existing literature regarding the unique mental health needs of women, and I also plan to discuss how we as clinicians may better accommodate these differences in hopes of providing more favorable outcomes for women in need of mental health treatment. Just so that we're on the same page, we are going to be looking at both biological sex as well as gender as a social construct in our discussion tonight, but the majority of our focus will be on gender, female gender, as it pertains to the social roles that women occupy, the family obligations, the gender norms, and how those are related to different mental health risk and resilience factors, as well as different mental health outcomes for women. So let's talk about why women are a special population. The term special population is used generally to refer to any group that is systematically at a disadvantage for various outcomes. We're going to use that term just in its broadest sense tonight as a way to organize our thinking about the uniqueness of women's mental health needs. It's important to focus on the special needs of women in mental health because there are differences in the prevalence rates for various mental health conditions, specifically some of our most common conditions such as depression and anxiety disorders. So that's one of the reasons why we're going to focus on women tonight. Also, that in addition to the different prevalence rates, that the onset, course, severity, the diagnosis and treatment of different conditions tend to vary by gender, and that also the adjustment to certain conditions are different for women than they are for men. Female gender is associated with a variety of key health determinants. We'll spend some time tonight talking about social determinants of health and how they differentially affect women. And that also is important to note that women and girls are at an increased risk for some conditions at various stages of life. And so we'll talk about how stage of life can present different risk and resilience factors for women and girls. Primarily, we'll be focusing on adult women tonight, but we will be talking about how mental health outcomes for adults begins with looking at the onset of some conditions and the presentation or exposure to certain risk factors, even in childhood and adolescence. Okay, in recent decades, there has definitely been an increase in the amount of attention that is given to exploring how biological sex and how gender are associated with different mental health outcomes. As far as biological sex goes, there is an increase in the amount of attention given to how differences in physiology, neurology, and hormones are associated with various rates of depression, of anxiety in particular, that there's also been a better appreciation for how gender as a social construct impacts mental health through a variety of mechanisms, and that there has been growing attention to how sex and gender interact with one another, as well as how they interact with various mental health risk and resilience factors that we'll get a chance to talk about. It's important for us to note the interplay between these factors as we try to best address the mental health needs of the women that we serve. There's also been a disproportionate amount of research on reproductive issues for women, that if you wanted to do just an interesting exercise, do a lit search on women's mental health, and if you work primarily with women, you may not be surprised by this, but if you don't work primarily with women, you may be alarmed at just how much research you're going to see on issues of pregnancy, fertility, infertility, postpartum depression and things like that. And I'm certainly not suggesting that those are unimportant areas, but if you did a similar search on men's mental health, you would see the discrepancy in how much attention is given to issues of reproduction in women's mental health. Okay. Let's talk about social determinants of health. These are the conditions in which we are born, in which we live, grow, mature, age, work, and eventually die. And that many of these are exists on a global level, and I think that it's key for us to be able to understand social determinants of health beyond just what we see in this country, because what is present, the social determinants of health and the distribution of them worldwide, is something that certainly impacts the individuals that we serve here for a number of reasons. That many of the people that we serve are first generation in this country, or maybe they have recently immigrated here from other places, or it's important for us to understand the cultures of their families and things like that, and that worldwide the impact of these social determinants of health have disproportionately and adversely affected women through having less control over their resources, less control over their choices, less control over their own bodies. And so much of the research, even on a worldwide scale, on social determinants of health has been focused on gender. The research on gender and social determinants of health has primarily focused on women for that reason, that women have been are more negatively impacted by determinants such as income and employment status, education, and that education often is just a corollary to income and financial resources. All of that goes along with access to healthcare resources. That generally speaking, the more money that people have access to, the better healthcare they can seek out. Social support is something that is not not a social determinant that is unique to women, and I think that it is important in men's mental health as well, but that there may be some differential factors that affect the extent to which women have access to social support as compared to men. Empowerment is certainly a social determinant that does negatively impact the healthcare outcomes of women, their ability to make choices about their own healthcare, their ability to make choices about such issues as having children or working outside of the home and things like that. So family structure as well is something that's important for us to keep in mind as a important factor that determines how women will access their care. Barriers to treatment. Many of our patients come from situations in which they are not free to seek health care as they would want to. And I see that based on the poll questions, that half of you have said that one of the most challenging aspects of working with women is overcoming some of the barriers to treatment, such as lack of transportation, lack of child care, few resources, and things like that. So this is something that I'm sure is not going to be new to any of you. Across diagnoses, women are more likely to have primary child care responsibilities. And along with that, women are more likely to bear the brunt of the financial cost of child care responsibilities, and as such, poverty disproportionately affects women. It's more common in women than in men. What is interesting about that is, well, a couple of things. One is that custodial single mothers are more likely to live in poverty than custodial single fathers. In addition to that, the poverty gap between women and men widens at the point where men and women are typically having children. So in childhood, there's an equal number of girls and boys living in poverty. However, once you reach approximately 18 to 24, you start to see that gap start widen, where women are more likely to live in poverty than men, and that gap continues to grow throughout the ages where adults are typically raising children, and it begins to close a little bit at middle age, but it never goes away. So what's interesting about that is that I think it highlights the extent to which you know, being the primary caretaker of children can often negatively impact one's ability to seek out services, that if you don't have the money to pay for them and things like that. And in fact, one of a recent study, the CDC National Health Interview Survey in 2010 showed that women were more likely than men to say that they failed to seek out healthcare services because of cost. So men may fail to seek out healthcare services for other women, but cost is more of a deterrent for women than it is for men. Stigma and cultural norms. This is not something that is unique to women, that where there is stigma against seeking mental health services, particularly among ethnic minorities, you're going to see a decrease in the willingness to seek services. Lack of family and social support are associated with failure to seek treatment as well. And that another barrier to treatment that is unique to women, or not unique to women, but does disproportionately affect women, is the presence of relationship conflict and intimate partner violence. Okay. Gender bias is something that we need to be mindful of, as it affects the kinds of conditions that we are going to screen for women. It also affects the diagnoses that we make, and perhaps affects the comfort level that our patients have in seeking treatment. So depression is the most commonly diagnosed mental health condition, and it is a condition that is where you see higher rates for women than for men. However, studies have shown that major depressive disorder is diagnosed more commonly in women than it is for men, even if you're controlling for the symptom presentation. So men and women present with identical symptoms, and clinicians are more likely to diagnose the woman with depression than they are with the man. And the opposite is true for alcohol abuse and dependence, that if you take men and women with identical drinking patterns, that women are less likely to be diagnosed with alcohol abuse or dependence than with men. And you can see how that discrepancy can be a disservice to either men or women, depending on which side you're looking at, but that it also speaks to the importance of us being able to have some more objective measures for screening for some of these conditions, which I'll get to in the second half of the presentation. And just a reminder, if anyone has any questions or comments throughout, I encourage you to submit them now. I will spend some time later addressing them, but I would love to get your questions now so that I can kind of tailor the talk to address some of those issues as they come up. All right, so in addition to the difference in how certain conditions are assessed and diagnosed for women versus men, that there's also some concern that some diagnostic criteria, particularly for personality disorders, may be gender biased in and of themselves. And when we talk about personality disorders, I'll go into a little bit more detail about that. I often have women who come to me for therapy and have expressed a preference for a female therapist. And so there's some research out there that suggests that, or asks the question, does concordance between the patient and provider actually matter? And results have been somewhat inconsistent, but in general, it seems that there may be some effect for diagnosis, that women providers may be more likely to diagnose certain conditions in women, and male providers may be more likely to diagnose certain other conditions in women. But that what has been more consistently shown in the literature is that the patient perception of concordance on various social factors is associated with their increased positive perception of the care that they receive. So when the patient perceives that there are more similarities between themselves and the provider, they tend to view their treatment experience more favorably. Okay, as I said before, women and girls face different risk factors throughout the lifespan, so we as clinicians need to be aware of those points in life and to try to tailor our assessments and interventions accordingly. Puberty is a particularly high-risk time in the life of adolescent girls that many of the most common mental health conditions have an onset in adolescence, and it's also important because some of the most potent risk factors are present by the time that girls reach adolescence. So that may be part of the reason why you have onset of depression, eating disorders, and other conditions that tend to pop up in adolescence. Pregnancy and the perinatal period are commonly identified as high-risk times, although the reasons for this are debatable. But in general, it's safe to say that there are some biological as well as social and lifestyle issues that may account for the increased vulnerability that women may experience during pregnancy and postpartum. Menopausal status is an interesting variable to look at, because conventional wisdom has been that women are at increased risk of depression during the menopausal periods, and that this is a time where we need to be on the lookout for new onset of depression in women. And although it's certainly true that menopause is a difficult transition for many women and results in a lot of changes to their lifestyles, that what is actually more predictive than just menopausal status alone is the presence of mood or anxiety disorders prior to menopause. So it stands to reason that women who experience depression or anxiety problems prior to menopause are more likely to experience depression and anxiety after menopause. Same with quality of life, that women who had high levels or high quality of life before menopause tend to continue experiencing higher quality of life ratings later or post-menopause. we simply cannot have any discussion of women's mental health issues without talking about the impact of rape and sexual trauma. It is a sad fact that sexual trauma is ubiquitous and that women are significantly impacted by its occurrence. 1 in 4 girls has been sexually abused. This compares to 1 in 6 boys who experience sexual abuse. Girls are more likely to be sexually abused by a family member than boys are. Both girls and boys are more likely to be sexually abused by someone that is known to them. 20% of child sexual abuse survivors are abused by fathers. 16% are abused by other relatives, and an additional 50% are abused by other acquaintances or family friends. But what's important about the increased likelihood of being abused by a family member is that intrafamily abuse is associated with some devastating psychological consequences. And one of the reasons for that is that intrafamily abuse is more likely to occur over longer periods of time, or to go unreported, or to go unchecked in other ways. So some of the differences in outcome come from just the nature, the unique nature of childhood sexual abuse perpetrated by a family member and what that means, but also that sexual abuse perpetrated by a family member tends to go on for longer periods of time. Now, here's something interesting about sexual trauma for adult women. CDC estimates that about 20% of all adult women have been raped in their lifetime, but this speaks to the comment that I made earlier about the importance of certain lifespan issues. Of that 20% of all adult women who have been raped in their lifetime, 50% of them were raped before the age of 18, and 80% of them were raped before the age of 25. So that addresses how important it is for us to be mindful of the risk factors that women and girls are going to face at different stages in their life. And in addition to that, here's something that I found interesting and very sad, is that that 35% of women who were first raped as minors, are going to be re-victimized at a later point in their adulthood. And that's significantly higher rates of re-victimization than women who were first raped as adults. So women who were first raped at 18 or older have about a 14% chance of being, or about 14% of them are raped again, whereas 35% of women who were first raped in childhood or adolescence go on to experience an additional sexual assault. As we all know, rape and sexual abuse are associated with all kinds of negative outcomes, including mood disorders, anxiety disorders, including PTSD, somatization, substance abuse, and many physical health outcomes that people with trauma histories tend to overuse certain services. They tend to have more medical problems and report higher levels of disability. Okay. Let me go back. We have a question here. What are your thoughts on sexual abuse and the connection to personality disorders? Good question. I think that it would depend on which personality disorder we're talking about. As it pertains to women, women tend to have higher rates of the cluster B personality disorders. Well, not all of them, but mostly borderline personality disorder is what we're talking about in general when we discuss personality disorders among women. 75% of all individuals diagnosed with borderline personality disorder are women. And if you look at the research on borderline personality disorder in particular, you'll see that the vast majority of people who meet diagnostic criteria for borderline personality disorder report some childhood traumas, whether that's physical abuse, sexual abuse, or other kinds of neglect or other traumas. I think that that connection, or at least that co-occurrence, cannot be ignored, that it's too powerful to just be coincidence, and that that in general, what I have seen is that people who experience sexual abuse, particularly early in life, tend to develop maladaptive patterns of coping. They tend to develop problematic attachments in their relationships, and they often have difficulty with issues like regulating their own emotions, that they experience more dissociative symptoms, and that all of these are associated with the dysfunction caused by borderline personality disorder. So I think that it is that sexual abuse or childhood trauma in particular, or in childhood trauma overall, is an important part of the development of certain personality disorders, particularly those that differentially affect women. However, it's not the only factor that most of the people who experience childhood traumas don't necessarily go on to develop full-blown personality disorders, but it may be just one of many factors that needs to also be accounted for when you look at other risk factors such as genetic predisposition, family history of mental illness, and things like that. So good question. Thank you very much for submitting that. Intimate partner violence, domestic violence is something that is another factor that we cannot ignore in the treatment of mental health in women. That it's certainly not to say that men are not impacted by intimate partner violence, but there are some differences in the patterns and the impact of abuse for men versus women. 1 in 4 women has experienced intimate partner violence, and 1 in 6 women has reported being stalked at some point in their lives. So these are very significant common events. 80% of women who have been stalked or have experienced intimate partner violence report having some short-term or long-term impacts of those experiences. And by impact, it can be anything from full-blown PTSD to subsyndromal symptoms, fearfulness, physical injury, safety concerns, missing work or missing days from school, needing legal or medical attention. So the ways in which women are impacted by intimate partner violence are varied. 1 in 5 female high school students reports being physically or sexually abused by a dating partner, again speaking to the lifespan issues, and that the majority of violence against women does start early in life. Something for us to keep in mind in our clinical work is that access to shelters tends to reduce the incidence and severity of future intimate partner violence episodes. Okay. If you work with women in mental health, then you probably know that women attempt suicide more often than men, but that men tend to complete suicide more often. Some of that may be due to differences in the means that women and men use in their suicide attempts. Women are more likely to use poisons and to OD, and suicide is actually the 15th leading cause of death for women, the 7th leading cause of death for men, according to NIMH. Some suicide risk factors may disproportionately affect women. Specifically, depression is more common among women than men. Marriage may be a protective factor against suicide for women. Some would argue it depends on the characteristics of the marriage, but that women who are single, recently separated, divorced, or widowed are more likely to attempt suicide. Interpersonal losses and relationship crises often precipitate women's suicide attempts, and that suicide rates tend to peak for women at about 45 to 54, and then again later in life at about 75. And this is true for both women and men, that social support and the ability to seek treatment are protective factors, although women and men do differ on their assessment of their social support, that women tend to view themselves as being able to access social support a little bit better. Even though I did say that there's a lot of attention paid to fertility and pregnancy and reproductive considerations, we have to talk about it because it is something that is unique to women and certainly affects the women that we will see for mental health treatment or for medical treatment. Up to 20% of pregnant women experience a mood or anxiety disorder. This is much more common during pregnancy for women who have a prior history of mood or anxiety problems. And this is a particularly vulnerable time for women because many of them discontinue psychiatric medications during pregnancy or while breastfeeding. That relapse is 5 times more common for those women who do discontinue medications. And this is especially interesting for women who have severe persistent mental illness such as bipolar disorder or schizophrenia, that they may be at an even more striking increased likelihood of relapsing during pregnancy because of discontinuation of medications. Infertility is something that is associated with depression more strongly for women than men, and this may go back to gender issues and how the social construct of female gender very often, and I would say almost always in most societies, includes motherhood, and that fatherhood is less strongly related to gender for men than motherhood is for women. Physical abuse is something that is very common among pregnant women and is something that is often screened for in obstetric settings. What is less frequently screened for is suicidal ideation. Pregnancy is often romanticized as a happy time, a time of emotional well-being, but this isn't the case, and that pregnancy is not a protective factor against suicide. So it is important for us to be able to assess for suicidal ideation during pregnancy. And a word about other risk factors for mood or anxiety disorders during pregnancy. Women who have experienced past adverse pregnancy outcomes are at an increased likelihood of developing clinically significant depression or anxiety during a current pregnancy. So women who have had miscarriages or stillbirths or women with histories of infertility are at a higher risk of developing mood or anxiety disorders during pregnancy. Okay, so I'm going to take just a minute to answer any questions. I don't have any submitted yet, but I'm going to pause just for a second to see if anyone wants to submit some questions before I go on. So. Okay, so I'm going to continue, but if anyone has questions throughout, please don't hesitate to submit those. All right, so now we're going to talk a little bit about specific conditions, and I'll give you all some tools that I hope will be useful to you. I'll start with some conditions that don't have different prevalence rates for women and men. Schizophrenia and bipolar disorder, there have been no consistent gender differences found in how frequently they occur, but there are some differences in the expression of these conditions or the patterns of functioning. For schizophrenia, women tend to have later onset of symptoms than men, and they tend to have higher levels of premorbid functioning. So those things may go together, that perhaps women, because of the later onset of symptoms, have more time to develop some of those adaptive social skills, adaptive skills for independent living. What I've seen kind of inconsistently in the research is that women may have more frequent hallucinations or positive symptoms. Again, that's not something that I've seen consistently, but it bears mentioning here. Women who are homeless and have schizophrenia have higher rates of physical and sexual violence than women who are homeless without schizophrenia, as well as women who have schizophrenia but are not homeless. So that's depending on the setting that you work in. If you work in a setting where you see a lot of people who are homeless or who have inconsistent housing, that's something to be mindful of as well. Bipolar disorder, again, there's no significant difference in the frequency in which the condition occurs in men and women. However, women are more likely to have rapid cycling bipolar disorder, and that women are also more likely to be hospitalized during a manic episode. And some thoughts behind why that might be the case are that perhaps women the symptoms that you might see during a manic episode are more aberrant or look more conspicuous in women and versus men, and that there are differences in substance abuse rates, that women with bipolar disorder are more likely to abuse alcohol and other substances than women without bipolar disorder. All right. On to the conditions where there are some differences in prevalence. The most striking difference is when you look at depressive disorders, that starting in puberty, the gender ratios for depression among women to men jumps from 1:1 to 2:1, and that may be because of the differences in how some of the risk factors for depression, such as trauma, and tend to present during adolescence. In addition to that, depression among women is a leading cause of disease burden worldwide. In fact, World Health Organization estimates that in general that depression will be the leading cause, the single leading cause of disease burden worldwide by about, I think they said about 2020 that they expect that to be the case. So it is extremely common. Some people refer to it as kind of the common cold of mental health. The higher rates of depression in women are consistent across culture, across race, and across other key variables that might be associated with depression. So it speaks to the pervasive nature of some depressive risk factors, as well as perhaps pointing to the biological components of depression. Along with that, depression tends to be more persistent in women, and that women are more likely to have comorbid conditions, which, as you know, with pretty much any physical or mental health condition, the more conditions you have, the lower your functioning is going to be, and that that is associated with poorer outcome. So I've included here some measures for screening for depression. The measures that I've listed for each of the conditions I'll talk about very briefly. I tried to stick with those that can be quickly administered, knowing that most people, women and men alike, present for first disclose problems with mental health in primary care settings or in medical settings, that the first entrance into treatment is very rarely directly to mental health, that people generally will go to their primary care or other medical care appointments and disclose some symptoms. And so screening very quickly for these conditions is something that is very useful to funnel people to the correct services or to providers that might be of help to them. For primary care or medical care providers, something that may be of interest to you is the Beck Depression Inventory. The FAST is actually the FAST screen, and that one it focuses on the affective and cognitive symptoms of depression, and kind of isolates the symptoms that could be somatic. Now that's difficult if you work in certain minority populations where depression is primarily expressed as somatic complaints. I feel tired, I'm not sleeping well, and things like that. But that's a scale that might be of use if you work in a setting where, say, everybody has low energy or is not sleeping well because they have chronic pain or because they have other medical conditions. Okay. Post-traumatic stress disorder. Also let me add that the screens that I am referring to you, I have made available, or at least have tried to point you in the right direction with some links that we will share at the end of the talk, and that most of them are available in Spanish, and some are also available in other languages as well. All right, so post-traumatic stress disorder. Men and women, women experience trauma a little bit less frequently than men do, but women are more likely to develop PTSD. And some of that may be related to differences in the types of trauma that men and women experience. Types of traumas most commonly reported by women are physical abuse, rape, and childhood sexual abuse. Rape tends to be associated with particularly poor outcomes in terms of post-traumatic stress disorder. 1/3 of all rape victims will meet full criteria for PTSD at some point in their lifetimes. And it's not quite clear if women consistently display different patterns of symptoms, but that some research suggests that women are more likely to exhibit self-blame. So they attribute blame to themselves for the occurrence of the trauma, and perhaps that might be related to poorer outcomes. Okay, I have included some screening measures, tried to stick with those that can be quickly administered. If you need any resources for this, the National Center for PTSD has a wonderful website, and that's included on the links that I'll share at the end of the talk as well, and that most of these measures are available through that link by request. So if you are a healthcare provider, you can request a copy of these measures, and they're free. Okay. Other anxiety disorders. Panic disorder, it has about a lifetime prevalence of about 10% in mental health settings, and it is 2 to 3 times more common in women than in men. Specific phobias are about 2 times more common in women than in men, but there tends to be a wide variability across feared objects. So women are about 75 to 90% of people with animal or natural environment phobias are women, except for fear of heights, which is a little bit more equivalent across sex. Um, Generalized anxiety disorder is diagnosed slightly more uh, commonly in women, and in clinical populations, obsessive compulsive disorder and social phobia are about equivalent among men and women. However, if you work with children or adolescents, you may note that OCD is actually more common in boys. Childhood onset of OCD is more common for boys than it is for girls. Alright, so I am including here some anxiety disorder screens for your reference. You may find them useful in screening for anxiety in general. These don't screen for any specific anxiety disorders, and in fact, the Beck Anxiety Inventory even screens for PTSD as well. Substance use disorders. Men are about twice as likely to meet criteria for a substance use disorder, but women do show very different patterns of substance abuse. Women, for example, exhibit a more rapid progression from controlled or recreational use of alcohol and other substances to full-blown dependence, and that pattern is referred to as telescoping. Women with substance abuse histories are more likely than men to report history of abuse or other traumas. So trauma is extremely common among men and women who have substance abuse histories, but it's even more common among women. And there's also differences in the pattern of or the types of triggers that men and women experience. Triggers to relapse for women are most likely more often interpersonal stressors or negative life events, whereas for men are more likely to attribute relapses to triggers such as being in the presence of people who are using, or being exposed to environments in which they used to use, or situations where they would previously have used. Men and women exhibit about an equal level of benefit from substance abuse treatment. However, something that is very important to remember in treating women with substance abuse is that child care is often a huge deterrent to seeking treatment. That fears about whether or not their substance abuse history or treatment seeking is going to be used against them in custodial decisions is something that keeps women out of treatment often. And if you're working in a setting where the goal is to provide residential care or very intensive substance abuse treatment, that residential programs that provide child care have better retention rates. So women are more likely to actually complete a program if they have child care options available to them. Okay, so I've included some substance abuse screening measures. You'll notice that the first one is significantly longer than the other screening tools that I have shared, and part of that is because it has some separate screens for all of the different types of drugs of abuse: alcohol, marijuana, cocaine, etc. the alcohol use disorders identification test, the Audit C, is a helpful screen in primary care settings. We use that all the time in the clinic that I work in. But with substance abuse, never underestimate the importance of just asking very directly, how often do you use cocaine? When was the last time? When did you first start? That very direct questioning has not about a variety of substances has not been shown to be any less sensitive than some of the more structured screening tools. Okay, eating disorders are extremely more common in women than men. About 85 to 90% of all people with eating disorders are women. Women and girls may be particularly susceptible to eating disorders, particularly in cultures where body image is directly related to self-worth and self-esteem, and perhaps that connection is not quite as strong in many cultures for men as it is for women. The onset of eating disorders is typically in adolescence and early adulthood, again speaking to the how critical it is for us to screen at different ages. And anorexia and bulimia are highly comorbid with mood disorders, anxiety disorders, and personality disorders. And anorexia in particularly has extremely elevated mortality rates, and so even though it's not necessarily something that is routinely screened for, perhaps we need to, if you work in a setting where there are you're working with perhaps this at-risk age group, it's very important to screen for eating disorders because of the high mortality rates associated with them. All right, so here are some eating disorder screening tools, and again, those will be made available to you through the links at the end of the talk. Personality disorders, we've talked a little bit about. Borderline, histrionic, and dependent personality disorders are the ones that are more commonly diagnosed in women than in men. There's some research consideration given to whether or not gender bias does affect the differences in prevalence in diagnosing some personality disorders. This is most striking in the diagnosis of antisocial personality disorder, which is overwhelmingly more common in men, but perhaps that is an artifact of the language of the criteria and the emphasis on externalized aggression. In the diagnosis of conduct disorder, the focus on destruction of property, theft, aggression towards people or animals, which is less commonly associated with girls. Among women with borderline personality disorder, symptoms tend to become less impairing with age, not in early adulthood, but I'm talking middle age and later adulthood. And I threw that comment in just because this is the one condition that is so much more commonly diagnosed in women, and that that in mental health settings, about 10% of the people that we see are going to meet criteria for borderline personality disorder, and about 20% will meet criteria if you work in an inpatient mental health setting. All right. Treatment implications for personality disorders. I didn't include screening measures because personality disorders are extremely difficult to assess in a screen, and should probably only be diagnosed in the context of an ongoing relationship in therapy or in treatment, unless the symptoms are so glaring. And that is because it needs to be more than just situational, that it reflects a persistent, pervasive, and enduring pattern. So here are some structured interviews, clinical interviews, that you may find helpful. All right, so general recommendations, I cannot stress enough the importance of screening across the lifespan and focusing on some of those high-risk times in adolescence and during pregnancy as well. The use of objective screening tools may help us to eliminate some of that, the impact of gender bias. It's not clear how, the extent to which gender bias does affect our diagnoses, but using objective measures that we apply routinely can help to mitigate some of those effects. It's also critical for us to assess for some of the common risk factors that affect women, such as interpersonal or intimate partner violence and other traumas, and to account for barriers to treatment in our work, and to try to problem solve with patients around those issues. And then I would also suggest implementing some screening protocols in settings outside of mental health, because as I said, that is usually not the first entree into receiving treatment for the majority of patients. That most women and girls will seek treatment through other means, or even if they're not seeking treatment, may be directed towards treatment through their OBGYN visits or through primary care visits. And I think even including screenings in schools would be useful, considering the fact that many risk factors first present themselves in childhood and adolescence. All right, so with that said, I am going to open the floor for questions if anyone has saved any for the end. If you do not have questions, please do not log off yet, as there will be some surveys that we'd like for you to complete, and also for the continuing education. So, any questions for me?
While we're waiting, Dr. Hunter, thank you so much for this presentation. It's very insightful and informative. Many of the audience have asked about getting a copy of the slides, and so I wanted to see what you thought. It is being recorded and it will be available on demand in about a week or so. But is it okay for me to send out a copy of the presentation to those who request?
Absolutely, absolutely. Okay. And I'm not sure if I said it before, but if I didn't, I can make references available. I didn't include them in the slides just because it was getting, kind of cumbersome, but I can certainly make those available if anyone is interested.
And some of the questionnaires, like the Beck Depression Scale, PHQ-9, is available on the website already in a PDF form where you can just print the form off. Some of the post-traumatic stress links and our resources are already on from when we did the post-traumatic stress coffee shop. So that's available on the site as well. But I can also go through the presentation and copy those links, and I'll place them on the website. And if the PDFs are available, then I can download those and put those directly so that people are able to just go to the site and print them off. And they will be in the, if you go to the share section under the general behavioral health, is where they'll be located under the either tools or links, depending upon what they are. So for those of you who'd like a copy of the slides, then email me at sajackson@msm.edu. That's sajackson@msm.edu, and I will email you a copy of the presentation.
Awesome.
I don't see any questions coming in. Are you able to see any?
I see no questions.
Not yet. Okay, gotcha. Well, just in case, some of you still may be typing, but I would like to say thank you again, Dr. Hunter. Thank you also to our IT, Mr. Quallen here. Thanks. Just definitely could not do that without you. I would like to make a few announcements that tomorrow, Thursday, we're going to have a primary care coffee shop on correctional medicine, and it'll deal with re-entry. So how to help patients transition from having care in a correctional setting to back into regular primary care or out into the community. And we'll be joined by Dr. Lewis Jackson, who is a primary care doc in the federal penitentiary here in Atlanta. Also, we will not have a webinar next week as it's the last week of the month, but starting back in March, on the second Wednesday, there'll be a webinar entitled Complementary and Alternative Medicine in Pediatrics with Dr. Beatrice G. And the first Tuesday in March, March 6th, will be our oral health webinar, our oral health coffee shop, and we'll be talking about oral health in a correctional setting. So just want to check back to see if we have any questions that have come in. Okay, you got a couple of thank yous. Okay, here's some questions. Alrighty. Are you able to see that, Dr. Hunter?
I see a request for a copy of the slides, and we can certainly send those out to anyone who would like a copy. I don't see any other questions. Are there others?
Okay. All right, so I think the email, people just wanted to see the email, have my email address to get a copy of the slides. Okay. So, alrighty. So this partnership between PrimaryCareForAll.org and the National Health Center, the National Health Service Corps, is directly supported financially through a grant from the U.S. Department of Health and Human Services, HRSA, and the Bureau of Clinician Recruitment and Services. An evaluation for the webinar will pop up in another window if you're using IE and another tab if you're using Firefox. Please complete it in its entirety in order to obtain your 1 hour of CE credit through AAFP. For those of you who are looking for contact hours or CEU, then please email me about that as well. So again, thanks everyone for your time and your attention, and have a wonderful evening.
Thank you.